Hello, my name is Jeff Taylor, and today is the last day of CROI 2016 in Boston. And I'm here today with Drs. Jordan Lake from UCLA and Todd Brown from Johns Hopkins, who are both experts in the fields of metabolic complications in HIV. So welcome.
Thank you.
Drs. Lake and Brown, thanks for joining us. So it's the end of the conference. Almost everything has been presented at this point, and I was just wondering what your impressions were of what got presented. There was a lot of stuff about PrEP, and of course that uses Truvada, which has effects on both kidney health and bone health. And what did you think about some of the data that got presented?
So I'll talk a little bit about tenofovir and TAF. You know, the big switch study was presented and by Joel Gallant, and it did show from a bone side that there was an improvement in BMD, about 2% by switching off of TDF to TAF.
And that was for treatment, not for PrEP, correct?
That's
Correct.
for treatment, yep.
Yeah.
Yep. So I think that it is, you know, the data, you know, the initiation studies with TAF and the switch studies with TAF have shown that it is better on bone. Whether or not that continues long term is unclear.
That's a big question.
But I think it's you know, it's definitely an improvement for patients who are at risk.
As clinicians, are you excited about using these drugs in your clinical practice?
Yeah, I mean, I see a lot of patients who you know, I'm an endocrinologist. I don't treat HIV, but I see them because they've gotten a DEXA and they're, say, 55 years old and they have osteoporosis, but they're otherwise healthy and they're active, and I would rather switch their antiretroviral therapy than to put them on bisphosphonates, for example. So I think that's a good strategy.
I agree, especially with both renal and bone effects of TDF, FTAF as a potential switch from Truvada is anticipated to be available in the next few months, and I think especially for postmenopausal women and older patients with chronic kidney disease, I think a lot of providers are looking forward to having that option, and patients.
Yeah. I mean, to date, they've had to go off a tenofovir regimen. It's the backbone of almost everything, at least among the preferred regimens on the guidelines.
Or dose reduce, which makes dosing more complicated if you're trying to remember to skip a day between pills. So hopefully those issues will be resolved.
Excellent.
And from a PrEP side, there was a presentation by Bob Grant about TDF and the effect of BMD and the offset effect, which was a question that had come up previously from...
Do you want to describe what the offset effect is?
Sure. So we know that tenofovir affects bone, or TDF affects bone, both in HIV-infected people and in uninfected people, and so in the realm of PrEP, you do see a drop in BMD with the initiation of PrEP, you know, TDF PrEP, by about 1% or so, 1 or 2%. And this study had a follow-up, had a washout period of, I think it was about a year, where they measured BMD during that year off of the TDF-containing PrEP, and BMD came back almost to baseline. And the question is, you know, what should bone be doing during that time for young people ordinarily, and whether or not they really without a control group not on TDF, it's difficult to say what their bone should have been.
Right.
And it's going to be interesting in the next phase, in the extension part of it. They're going to go back on TDF and to see if you see the same effect, if it's a greater effect or a lesser effect. You know, in the second line study with antiretroviral initiations, this is people who had been on antiretroviral therapy, who were failing antiretroviral therapy, and then got a second line antiretroviral therapy. They saw the same drop in bone mineral density with initiation of a second ART regimen. So whether or not you see the same thing with PrEP is it'd be interesting to see.
Yeah, I think there are still some questions around persons who might need to go on and off Truvada for TAF and what the window is between those increments, and whether do you need to wait a full year? If you're every few months going back on or off, can you still see return of your bone mineral density? Or if you're on it for some extended period of time and then go off, do we still see return of bone mineral density? I think those are unanswered questions, and for very young patients who haven't met their peak bone mineral density, what are the longer term consequences of that, I think.
And how many of those studies have been done in women? Because certainly that's a more important issue, especially as women get older.
Yeah. Let's see, there was one in Africa, I believe.
There is, but I don't know that DEXA.
Yeah, I can't remember off the top of my head.
Yeah, so more work needs to be done, obviously.
Yeah.
Well, that's the bone. You were talking about kidneys, another organ impacted by tenofovir use. What were your thoughts on the renal data that was presented?
I think similar to the bone data, the TAF data is very encouraging with improvement in renal biomarkers, certainly. Again, as mentioned before, having the option for patients with chronic kidney disease will be nice. They did, in the ECF TAF studies, allow a much lower...
ECF TAF for our audiences, elvitegravir, cobicistat,
elvitegravir, cobicistat,
Stribelda,
FTC, and TAF.
And Genvoya, I guess, is the new one.
Switching to that, you did see improvement in renal biomarkers, and they allowed patients who had creatinine clearance or kidney function of 50 or less, which is below what was previously on the package insert. So a little bit more severe kidney disease, patients who had more severe kidney disease did very well with switch to TAF, and certainly patients have kidney disease for many reasons that are completely unrelated to tenofovir, like high blood pressure, and so it just improves the options available to patients who have chronic kidney disease.
Excellent. Yeah. And then, of course, inflammation has been a huge issue in HIV. I think is the root of a lot of the complications that people, even though they're completely virally suppressed, are experiencing. And there was some interesting data that came out about some of the interventions that we thought might be useful, like aspirin. Do you want to speak to those?
So I think the pathways, inflammation is a complex concept, and there are multiple pathways, and there are multiple checks and balances. And while some interventions that we've tried had very good scientific rationale, when implemented, they may not have reduced chronic inflammation to the extent that we expected. And so personally, I think we just still need more research around what pathways should be targeted, what are the other confounding factors that may have prevented that intervention from working, one of which is just continued living with the virus, something we are not yet able to take away, but further research is needed to find an anti-inflammatory benefit that is an adjunct therapy, either to be added later and people you've identified have higher levels of inflammation, or early on with start of treatment to prevent some of these complications that we believe to be inflammation related. I think that's where we need to continue to go.
Yeah.
Yeah, the treatments for this sort of inflammation, ideally you'd like something that is cheap and easy to take and not too many side effects, and aspirin fits that bill. But in the data that was presented, I think was a little disappointing. They had some nice preliminary data that was presented at IAS a few years ago, and this follow-up study with the ACTG didn't show the same effect. It did show that aspirin did what it was supposed to do, so it wasn't an inert compound, but in terms of platelet function, but it didn't show that there was effects on markers of immune activation.
Now, is this powered to actually look at endpoints or just at markers?
Just at markers, a short study, yeah. And then maybe on a little bit of a brighter side, so Alison Eckhart, I don't know if you saw the poster, her vitamin D poster, looking at vitamin D supplementation in kids, so the equivalent of 600 international units 2,000 or 4,000 international units daily, but she gave it as monthly doses. And there was a suggestion of improvement in some of these immune activation markers, and more in the higher dose group. So I think the vitamin D question is still out there. Whether vitamin D is well, good for anything, but whether it's good for inflammation, I'm not sure.
Well, it's certainly still recommended to maintain and improve.
Yeah, so I think that you know, the IOM recommends 800 international units daily for most people, and I usually boost it up a little bit in people with bone problems, but trying to figure out if there are other endpoints that vitamin D would be helpful for. It's still an open question in the general population and the HIV population as well.
There's definitely some suggestion too that appropriate levels of vitamin D may help T cell recovery with initiation of antiretroviral therapy, but they're very small studies, so I think that's still a question. But it just speaks to the fact that vitamin D has potentially multiple ways that it can improve both inflammation and immune function. So, as Todd says, still something to look out for. And, and yesterday there was a discussion about exercise again, because some of the anti-inflammatory focus has been on, is there a pharmaceutical intervention that we can provide? But risk factor reduction is still very important. So we know that smoking cessation and diet and exercise, all of these things are in the general population things that we know that work, and the data in HIV infection is equally preliminarily suggestive, although there haven't been large exercise studies. But there's no reason to believe that the things that you normally would do to improve general health would not affect inflammation as well in HIV.
Yeah.
So listen to your mother, take your vitamins, eat right, get plenty of sleep and exercise.
Lots of fruits and vegetables.
And the other simple thing maybe is to take your HIV medications.
Yes.
And so Jose Castillo it did an analysis in the Max, which was a poster looking at HIV-infected men who were suppressed on their antiretroviral therapy, and looked at biomarkers of inflammation, sort of the usual suspects, a whole big panel, and looked to see whether or not adherence. So the men come in every 6 months, and they're asked, have you taken your antiretrovirals in the last 4 days, and how many doses have you taken? And you can calculate who's 100% adherent versus less than that. And it turns out that the men who, even though their viral load is completely suppressed, the men who were sub 100% adherent had higher levels of IL-6 and TNF-alpha, suggesting that maybe if we did a single copy assay to look at their viral load, maybe there'll still be virus there. Maybe we're defining it by the people who are non-adherent, that they, even though they have an undetectable viral load, they have other behaviors that may increase inflammation. But I thought it was an interesting analysis and potentially a very simple intervention to decrease systemic inflammation if it's a cause and effect kind of thing rather than confound it.
Yeah, because that was just a correlation, right?
What's that?
That was just a correlation that they discovered.
That's right. Yeah. So the next step would be to take these suboptimal, the people who are suboptimally adherent, and try to get them 100% adherent, and with regimens that are easier to take and single tablet regimens. I think that would help. And the long-acting regimens that were big news at this conference. Indeed.
They were, and we need more metabolic data on those as well. So, But so far, I mean, that would certainly address adherence issues and ease of administration, and so I think that's very promising.
So we were talking about exercise, and one reason people exercise, obviously, is to maintain a healthy weight, and there was some interesting data that came out about the types of fat people have and the effect it has on their health, and a number of different ways. Do you want to speak to that?
I think early on, we worried certainly with some of the older HIV regimens about lipoatrophy and the negative effects of that. And as time goes on, there's more growing information about the negative effects of visceral adiposity, both in HIV infection and in the general population, and how it's particularly pro-inflammatory, associated with cardiovascular disease, associated with liver disease, and in some studies, but not all, HIV has been associated with visceral fat accumulation. There's also the problem of generalized obesity growing, certainly in some parts of the countries in the HIV-infected population. And so we also have to think about what are the interactions between any lipodystrophy that may be ongoing or any antiretroviral therapy-induced changes in fat and just general health, regular obesity. And so there's a lot of data there, but one thing that I think is important that came up a little bit in the poster sessions is we know that HIV infection is associated with disruption of gut health, gut integrity, and leads to microbial translocation that then furthers chronic inflammation, but obesity is also associated with that pathway. So optimal control of both and maintaining a healthy weight may reduce the stimulus for the chronic inflammation as related to gut health. And there will be some studies coming out or starting soon with probiotics and other interventions to try to improve gut health. There's a poster here on one of the drugs for constipation, but to see if that improved gut health, and it did not. But
which drug was that?
Lubiprostone.
Oh, okay.
But there are other interventions in development to try to improve gut health, and maintaining a healthy weight is certainly one of those interventions.
I think looking at the mechanisms underlying the relationship between obesity, excess fat, and inflammation and end organ outcomes is really critical, and that came out in the session yesterday that Grace McCopsey and Suzanne Crowe were talking. Suzanne Crowe was talking about the immunopathogenesis of HIV complications, and Grace delved in a little bit more with visceral fat, and it does. You have people don't realize or may not realize how much of an inflammatory organ adipose tissue is, and especially when adipocytes grow. And you get this very pro-inflammatory state, and I think that whether or not that the expanded fat mass in HIV and this inflamed adipose tissue is any different than in non-HIV patients, I think is an important one. Do these M1 pro-inflammatory macrophages that reside in the adipose tissue in an HIV-infected person with increased visceral fat, are they any different than the general population? And I think that's an interesting question.
Yeah, and certainly despite the improvement in meds over the years, there's certainly a group of long-term survivors who still grapple with that. It doesn't go away even though they switch their meds, and it's troubling on a lot of levels for them at least.
Yeah, absolutely.
It tends to be very stigmatizing.
And on sort of a similar note, one thing that came up in the session yesterday is the concept of fat health and not just fat quantity. And I think we are beginning to have a better understanding that fat can be healthy or unhealthy at any range of quantities. And so the goal would be to have normal amounts of fat that is also healthy.
Right.
And so we'll be looking, I think, at future studies as to how people's fat is actually functioning, because some people have very healthy fat even at large quantities and don't seem to have the metabolic disturbances. It's referred to as metabolically healthy obesity, but it's a known phenomenon that you can have a lot of fat and it can be functioning very well, and you tend to be more healthy from a metabolic standpoint than folks who may have much less fat, but their fat is not functioning well. So understanding fat function, and part of that is understanding the immune life of fat, is something that I think is going to be a focus too as well.
Yeah, well, certainly Americans are obsessed with fat, so I think that obsession will continue, not just quantities, but how good your fat is. Terrific. Well, thank you for sharing with us today. Is there anything else, any other last parting thoughts you had about the conference or where kind of the field of metabolics and HIV is going over the next year or so.
I think it was a good year for metabolics.
Yeah,
There was a
I
lot
think
of provocative discussion that came up, and hopefully even more next year.
Yeah, and I think that as we've been seeing in the last few years, a lot of the metabolics studies are looking at it through the perspective of aging and looking at that intersection, because all of these diseases increase in the general population with
Right.
increasing age. So trying to understand, how do these diseases act in aging HIV-affected people, I think is important.
Yeah, I know one of the sessions they had a slide that referred to it as the silver tsunami. So I think
Exactly.
it's almost upon, it already is upon us, I guess. So we'll have to learn to swim with it, I guess.
Nice.
Terrific. Well, thank you, Drs. Lake and Brown, for joining us today.
Thank you.
My pleasure.